Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Today, POMA does clinical rotation prep. This is part one of a two-part episode. Thanks for joining us.
Welcome, everyone, to the POMA Does podcast series. Today, we have myself, Sophia Clevin. I am a second-year medical student at the Philadelphia College of Osteopathic Medicine. I'll be going into my third year, and I am joined here by Matthew. I'll let him introduce himself.
Hi, guys. My name is Matthew Bambino. I am a fourth year here at LECOM and at their main hospital for my clinical rotation site, which is Mill Creek Community Hospital. And then I will be, I'm only fourth year now, for another month or so, or a couple days. And then I'll be graduating for residence and starting family medicine here at LECOM Health, Mill Creek Community Hospital, too.
Awesome. Very exciting. I was able to, as an incoming third-year medical student, gather some questions from my peers about their burning questions for going into their clinical rotations. So thank you for helping us answer all those questions. I'll start off with the easier ones. I call this category resources / what to bring. So what were some pocket resources that you felt were helpful to take with you? I feel like we get so many different resources thrown at us. What did you feel was actually something that helped you on rotations?
Definitely. Great question. So I think starting off, my first one I got was actually Pocket Medicine. It's a little pocket handbook, very detailed for a lot of basically anything, a workup, anything that you would need for general internal medicine. That's probably the first thing I got. How many times I used it, different story. So it made me feel better having it because I knew it was there, and I probably carried it for the first rotation or two. And then I quickly transitioned just to things on my phone. It's just a lot easier. It's a lot quicker. You can search, control find almost like how you would on a computer. You're not flipping through pages, which I really liked. And so for that, I really used Up to Date a lot. We have a subscription through LECOM that we can use and access, and then I could also access it through the hospital. And so that's honestly what I use the most. It gives you the most wealth of information, and you can, kind of just go through things as you need them. So
awesome. That's really helpful because certain things like remembering what are the normal values for things like that, people were anxious about.
People too, actually, would for lab values and stuff. So typically in the EMR, they gave you, your normal. So you don't have to, remember them like you would have to in your first 2 years. But also I see a lot of people carry, it's like a foldable clipboard, and it has all the lab values and normals and fishbone labs or whatever they're called. It has all that stuff so that you can quickly learn and reference them. You can get them off Amazon for $10-20 probably. I never use one personally because, again, you're walking around a hospital. You don't always have some place to put something. And I'm not always wearing my white coat because I tend to run a little hot. So that was always my excuse. And so you can't really fit them in scrub pockets or something all the time. But a lot of people would carry them or just their computer too.
Okay. When it comes time to presenting to attendings, and a lot of people carry around a little pocket notebook, do you ever use your phone for that? Writing in your notes app, or do you think that's pretty taboo still and you need that pen and paper?
I haven't seen many people present from their phone. If anything, I've seen people present from their computer or their iPad or something. I think those are more accepted because that somebody's not texting, so to say, on it. I still think there's that stigma around the phone. If somebody sees you on it, they're assuming you're texting. Other hospitals, bigger institutions are more progressive. I'm not sure. But I know for me personally, I still like to write things out. And even you kind of quickly get away from that too, because you'll find in the hospital, things are just moving very fast. And so you catch up mentally very fast. And so you have to pretty much remember a lot of things. And then only if you have to reference a lab value or something so I know for me personally, my patients I would be following, I would have a printout sheet of, who the patient list was for the day. So our census. And you don't have a lot of room to write notes on at least ours. And so I would fold the paper in half, kind of like this. And then in this area, I would do fishbones for labs and, any pending tests, we're getting an echo today, things like that. And that would be part of my morning rounding whenever we would do our pre-rounds and then we would round with the attending. So that's what I would do for any kind of presentation. Every attending is different on how much information they want to know. I think in the first 2 years, we are trained for the history and physical to really get this huge cohesive thing and know everything about the patient. Well, at least on inpatient medicine, it's like, why are they here? Anything that's relevant, because you're taking up an attending's time. And so you want to present things that are very pertinent to them. Now, again, every attending's different. There's going to be outliers who want to know absolutely everything. But most of the time, through my experience, it's been, why are they admitted? Significant past medical history. Do they have diabetes? Because diabetes affects everything. That kind of thing. So you very quickly start just learning from your just mental notes instead of actual notes.
And then as far as like other things we should bring with us, are there any like silly things that we wouldn't necessarily think about? So things like that would be like maybe on surgery rotations, you might want some compression socks. Any like silly add-ons we'd want to bring with us?
So give a little background for me. I used to want to do orthopedic surgery. So I actually have a good side of the surgical specialties and also, clinic and inpatient medicine and all of that. So I think that's a benefit for the podcast here. But I think it sounds funny, especially us being like in our 20s, maybe 30s, because I just entered my 30s. Compression stockings are useful in the OR.
Okay.
A lot, and your feet start hurting. And so I've seen some surgical residents who are definitely a couple years younger than me, maybe like 28, and they already have like varicosity starting because they're standing all the time. So surgical or compression stockings, or like I never bought compression stockings. I just wore longer socks, that were tight fitting. So that is actually something that may be useful. For other surgeries, like for the surgical field specifically, if you're interested in orthopedics, I know something that they really harp on for med students having would be like a pair of shears. I actually have some in my bag still. So I got like these off Amazon. I think they were like $20, came in like a little case, and they're pretty like sick quality. But they're good for removing casts. They're good for, cut in like trauma situations, for cutting clothes off, like anything like that. I think those are a good investment because the residents seemingly never have them on their person. And so they will then be wanting one, and it looks good if here you go. So anything you can preemptively do like that kind of gets you a good look on clinical rotations.
Matthew is showing they're kind of like trauma shears. Is that how you describe them? But they're heavier duty to me.
Yeah, trauma shears. Mine are foldable. And so, if you just search on Amazon, that's how I found them, just trauma shears, and just go through what you like. They make ones that are unfoldable. They make like cheaper ones. You can go to CVS, I know, because I was on an ortho audition, my first one, and I had not got my trauma shears yet. I kept putting it off. And so I went to CVS and got a pair. And I do not recommend that pair because they kind of stink, but I at least had something to offer until mine got shipped. Thank God for Prime.
All right. So we'll filter the best ones on Prime, and then we'll get that.
Yeah, definitely. So I think those are some ones for surgeries. Gen Surge, nothing specifically comes to mind that I needed. The trauma shears were helpful again, but that's kind of like across, like in ED, they may be helpful depending on how busy your ED is. IM, they could be helpful. IM rotations, I'm just always using my stethoscope. I always have it around my neck. It's the typical doctor thing that you would see. Depending on how good you want to be with like neuro stuff, you can be carrying your tuning fork. I know our neurologist, they're like a long wooden tube Q-tip at the end. It's a wood stem and then a Q-tip at the top. And he breaks those, and that's how he does his fine touch. So he has a point then whenever he breaks. You could carry stuff like that. I know I have a couple in my bag. But again, it depends on, what's going on. Because if you have your lab coat, yes, you can carry everything with you. You're not going to want a bag carrying around with you all day in the hospital. So it's things that you can quickly have on your person. One thing, have a couple like alcohol swabs. You can always get them at a nurse's station. Have a couple just in your pocket. On surgery, I guess, sometimes I had a third year on with me actually earlier this year, and she did that. And it was very useful because about 5 times throughout the rotation, we needed something. And she was, and I was like, you go, girl. Awesome third year. So I actually learned something from the third year for that one. Yeah, other than that, I think that's fine. Because if anything else you need, I could just go back to the lounge and grab my manual blood pressure cuff if I need it. Otoscopes and stuff like that, I honestly never use because in the clinic, they have their own most typically. So those are probably the surgery side is what I would really recommend, the shears and stuff.
Yeah. And then as far as an extra change of scrubs goes, did you always have one in your car or did you bring it in with you? Did you not bring them? What are your thoughts on that?
I guess it depends how OCD you want to be. I did have one instance where I wish I had a change of scrubs in my car. We were in clinic and a patient came in with bed bugs. And of course, whenever that happens, you handle everything professionally on your end. But then from a logistical standpoint, after the patient leaves, that room needs completely deep cleaned, which is not something that we do as the medical students. But I remember talking with the attending and he was like, I was freaked out because it was my first experience with it. And I was like, I just felt gross. I felt like they were crawling on me. He was like, Matt, you just go home, take care of you, like you're fine. Because I think we had 2 patients left that day. But that was one instance where I could have went to my car, like got a change of scrubs, or I could have changed, or I could have went somewhere to like shower. But it was honestly probably best just to go home and, mentally get myself together. But that's just kind of like a funny story. Regarding the hospital, so we have access to all the OR scrubs as long as you have gotten your access approved by HR or blah, blah, blah. So if I ever needed to actually change out of scrubs, I could just go there and change. So I didn't ever carry an extra pair of clothes if I was in the hospital because I always had that option. But again, maybe I know some hospitals I've been at, they may not allow that access. They may have the scrub machines that you only get 2 tokens. So you could at max have 2 pairs of scrubs, hospital scrubs at a time. Depending on if you have like a locker, I don't think it's a bad idea, like your own personal locker in the hospital or wherever you're rotating. I don't think it's a bad idea to have like a change of scrubs in there.
Awesome. Thank you. And then I have some questions kind of transitioning here into more like general rotation questions. I think the biggest one that every medical student wants to know about is how can we be helpful?
So whenever you guys all start clinical rotations, you're going to quickly realize that you're not very helpful when you're in the way. But I say that jokingly because as a medical student, you're not the busiest person on the team. So therefore, you actually have a lot of time in, I guess, a loose sense of the word to like spend more time talking with patients. You'll find that some patients are needy. And by that, I don't mean that in any kind of bad way, but just recently I had a patient and I like referring to them as the angry Sicilian because I'm Italian by my heritage. And so I very quickly, 1, jived with her and 2, knew where she was coming from. She wanted to talk. And so as the medical student, I could provide that. I could talk with her. I can provide that level of, therapy, so to say, by talking because that's kind of what she needed for part of her, treatment. So that's something very beneficial if you realize that as a medical student that you can provide that stuff. Again, that's not to say go spend 2 hours talking to a patient if you have other things you have to be doing that the resident or the attending told you to do. If you're not doing anything, you can talk a little bit more with patients is what I'm kind of getting at. Another way to be helpful, just having things on person, kind of like the alcohol swabs, those things are always helpful if you just are like always willing to help. I guess that's kind of the root of what I get at for how I view medical students to be. You should just be present and be willing to help in whatever way necessary. Even if you don't know what you're doing, if you don't know how to do a procedure or if you feel uncomfortable doing a procedure and somebody asks, I was always willing to like either watch first or if I felt comfortable just with knowing what's going on, I'll try first. I don't care. But just being present, I think, is probably the best way to approach from a medical student standpoint. And try not to be in the way. So there's a hierarchy in the hospital. So there's the attending. If you're thinking about doing a procedure, the attending should be closest to the patient because the attending's probably doing the procedure. And or the resident is. So any resident should go in front of you and then the medical students and so on and so forth. So don't stand right next to the attending unless it's just you and the attending. Just be aware of that because the residents should be learning first, then the medical students should be learning if you're in a place with residents. I know at our hospital, we have residents, so we don't spend a huge amount of time with the attending in the hospital, but we spend a ton of time with the residents in the hospital. And so there's a lot of teaching going on, resident to student basis, which I really enjoyed.
I actually had a question based on that one, like working with residents versus attendings. Did you notice a big difference there in how you learn as far as what knowledge they can like impart on you? Do you tend to learn better with residents or with attendings? Like, how do you feel that dynamic usually plays out as a medical student?
As everything, it depends on, the resident and the attending. For a generalization, attendings tend not to have as much time to teach you. Whenever they are teaching you, it's very compact and it's very quick. And like on orthopedic surgery, like you would just get pimped by attendings, just whether it be anatomy or an approach to, procedure or whatever you're doing. And I wouldn't almost call it teaching per se, because they're just asking you questions to gauge your knowledge base. Whereas the resident, they may do that too, but at least in my experience, it was more of a discussion. It was more of an actual one-on like small group teaching opportunity where the resident's explaining the pathophysiology, where they're going through the treatment, why this treatment would be better over this treatment or this workup better than this workup. I did that a lot more. It was more collaborative, which I learned best with. Now, some attendings are like that too. It just depends on how busy they are, if you're in clinic or not. So one of the neurologists I rotated with, his clinic clinic wasn't terribly busy, so he had a little bit more time to teach. And so he would be more of that collaborative, conversation teaching, which I enjoyed. I always personally treated attendings with, the utmost level of respect because they have no time. And so I don't want to make your life more difficult. If you're willing to teach me, I will be a sponge and I will absorb it. Unless I felt very comfortable with the attending, you kind of feel the vibe. Can you ask a question on further clarification? It's not always surgeons tend not to be the best people to ask that about. Just because they're a surgeon, they get in, they cut, they go, and then they move on. They don't always have time to explain things, at least from a historical perspective with, how surgery residents and how surgery was, the angry surgeon, it's changing, I will say, but.
That's good.
Yeah. Residents are they're a huge lifeline. They are a huge connection to make. If you're going to or if you're at a rotation and they have, say you want to do internal medicine and they have an internal medicine residency and you're with those residents, they have a huge say on your evaluation if you want to go there. Because the attendings will ask, what did you think of Matt Bambino? Oh, I either hated him or, oh, we really liked him. He was very helpful. That carries a large amount of weight because, again, you only get maybe a couple minutes a day with the attending, but you get the entire day with the residents most often.
That was really helpful. And then as far as some more just general rotation tips go, how did you best prepare for doing rounds? I
know my first IM rotation, so I had internal medicine, I think it was my second rotation of third year. So my first one was psych at a VA hospital. And it was mainly outpatient, and I have a psych background, so I was very comfortable with that. And it was more of a shadowing experience, to be honest. But whenever I got on internal medicine, I know the first thing I did was really observe how the residents presented their patients to the attending. I went about there. So the first week, I tagged along with a resident closely. I tried to make it the same resident. That way I got, the same experience. And really learn their ways. And you kind of figure it out. You can watch the residents and see which ones would mesh best with you, just their personality. So that's what I gravitated to. So the resident that I attached myself with, he was very similar to me. And so I was like, okay, I can learn from him and I can see how he goes about this. And then after seeing what he did, I then just replicated it. And so basically it just starts with, you have patient A, and before you even go see patient, you read their history and physical in the computer so that way you're up to date on why they came to the hospital. Then you can quickly skim through most recent notes depending on where they came in. And this may be a change of rotation. This patient may have been here for a week and now it's your patient. So now you have to catch up on everything that has happened. Now you don't have to become a super scholar and spend 5 hours just on this patient reviewing their notes because you don't have that much time. You have 15 minutes. So just quickly go through things and then go through vitals, labs, all of the items that have been taken over the last 24 hours, because you get vitals at least every Q shift. And then labs, you pretty much get daily. So that way you can track them. They're in the hospital. You might as well be getting stuff to make sure they're all right. And then check their medications and just go through, familiarize yourself with that. And then go see the patient, see how they're doing. Say if they're with pneumonia, you're obviously going to be asking more centered respiratory questions, how you're breathing and checking their O2 stats. And you'll be surprised how much stuff you miss as a third year and then how much stuff you get as a fourth year, but you still miss. And then you just keep making mistakes. Somebody points them out and you just keep correcting. Don't feel bad about it. I had one probably a month or so ago. It was a very routine question that I should have asked, but it just slipped my mind. And the resident asked, hey, did you ask this? Oh, you know what? No, just don't lie. I didn't do it. Hey, you can always go back and ask the patient. I have no qualms doing that. I'll be like, okay, let me go check. I'm very jovial and even keeled and, in the hospital, I tend not to get too flustered about things. So that's how I would basically prepare for rounds. You just kind of learn as much as you can in that little 15-minute period. Yeah. And then go to the patient and do the physical exam. Probably the biggest thing I would say for rounding, or if, after you're done and you present to the resident, because that's how a lot of times we did at our hospital. Fourth years would present to the attending, but third years would typically present to the resident. And then the resident would, you go see the patient together with the resident. And then whenever it was attending time to round, the third years kind of were in the, back just following along, contributing if needed. If the resident referred to you, hey, what was that lab result? And then you would know it. And then fourth years would also kind of almost act like a resident. They could present to the attending.
So you talked about a lot of rotations that kind of stood out to you because you like them and so you have a lot of good stories about them. But how do you approach a rotation where you aren't typically interested in it?
You lie to yourself and tell yourself that you want to do it. Jokes aside, I know some people would do that. That wasn't very feasible to me. I approached it from a respect point of view. So the attending I'm with, so like OB-GYN, I had no desire to really do OB-GYN, which is kind of common in family medicine, even though we still do it. But I still had respect for my attending because this is their profession. And so they can still teach me something, and I can still be of help to them. I can make their life, their day a little bit easier. And so that's how I always approach the stuff, especially in third year at LECOM. We take shelf exams. So we take the NBME, like after every rotation, we take this big exam. So you're always preparing for something, typically, at least we were at LECOM. And so that's also a driving force. You're trying to learn things on rotation, that way you can succeed on this test as well. And it also gives you an opportunity if you're doing your review of study material and you don't understand something and you're with that specialist and you have downtime between patients, you can ask, hey, I'm not really getting this. Or if you see that patient that you don't really understand this disorder, you see them in the office, and that's a perfect opportunity to talk about it more with the attending. And so that's how I would approach the things. Just have a respect for the attending. Because again, they signed up to teach students and you have to be there together for a month. And so let's make it as painless as possible, even if you're not interested in it. So
that's helpful for sure. And then as far as some things you shouldn't do when you're in the hospital, so what are some big no-nos that you learned?
Ooh. So in surgery, regardless of where it is, if it's ortho, if it's gen surg, don't remove dressings or mess with wound vacs. Don't mess with anything like that, as in touching, unless the attending tells you to. I've heard stories of on ortho, knee replacement happens and you see the patient later that day. And for some odd reason, the med student took the ACE wrap off and took the bandages off. And the patient's then just sitting there with, now their incision just laying open. What are you doing? Don't touch it. So only touch that kind of stuff if somebody tells you to. It's completely acceptable, at least in orthopedics. You can move the blanket. You can observe and report your visual findings of the incision site and the dressings. Dressings are clean, they're dry, they're intact. You don't see any leakage around, or you see a little bit of blood. How much, where's it located? That way you can tell the resident or the attending, hey, this is what I see. And then you'll come to realize, what is a normal progress of post-surgical bandage, leakage, and all that kind of stuff, because you don't know that yet. But you can at least report visually what you see. So another big no-no is, and this is a very fine line, especially on audition rotations in your fourth year, you want to show that you're interested and you want to show that you're hardworking and that you'd be a good resident. You want to show all these positive qualities, but you don't want to be too much of a gunner and then step on people in the process, because that turns people off. So I've heard of surgical auditions for gen surg. Some students just want to show how good they are and they step over people. They talk over people. Not that it gets physical, but you kind of have to know your place as a student and answer whenever you're spoken to. If somebody's asking student A a question and then student B answers it, you weren't asking a question, student B. And so it's just one of those things until the person asking the question opens it up to the group. Does anybody know what this is? Then you can answer. But if I'm talking to student A, I want student A to answer. I know in orthopedics and in gen surg, that was very prevalent. In other rotations, it's not as prevalent for that, but still, I always hold to that. I let whoever's being asked the question, I let them answer. And then if, it's opened up, then I answer. And so you want to show you're interested, but you don't want to step on people in the process, because that just shuts people off to you. It shows you that you're not a good team player. And always be willing to help people, regardless of where they are on the hierarchical scale. Attending, residents, nurses, janitorial staff, house staff, it doesn't matter. I will help in any way I can if I have time. As a student, you have a lot of time, so you can help with a lot of things, because people see that and they see that you're, I guess that's more of a do thing. They just see that you're willing to help and you're willing to be a team player, and, you're just present to help make people's lives better. It sounds very cliche, but it's true.
No, that's great advice. And then we've talked a lot about surgery, and that was actually a huge thing, that questions that students had that just kept coming up and up as I was asking my peers what to ask you today. And they were wondering if you had any tips for succeeding in surgery rotations.
Yeah, so surgery rotations are very simple in terms of the thing to succeed and how to succeed. The little blueprint, so to say. So for any type of surgery, you're going in tomorrow and you're going to do, a lap chole, let's say. First thing I would do is go on YouTube, or any of the things you can watch, videos on nowadays, and just look up the procedure so you're already familiar with what you're going to see. So I know for ortho, one prominent company, Arthrex, they make a lot of, different implants and, endoscopic procedure stuff. Like they're just a big company in that. And they have videos on their websites for a lot of the stuff. So like whenever Aaron Rodgers had the speed bridge technique, Arthrex has an actual video showing you schematically how to perform that surgery. And so you have access to that. You don't have to be a surgeon to do that. You can just go on and find it. You just have to know the nomenclature, like the specific type of speed bridge technique. So that way you make sure that you're watching the right thing. So conceptually, you know what is going on. So that's the one side of what I would do. Just get familiar with the approach. So that is, incision and getting in. So if you're doing a knee replacement, from incision to knee replacement and then taking everything out, putting everything in, and then coming back out. Like that's all the approach and the entire procedure. And that's one side. The other side is just the anatomy. So that's what surgeons will pimp you on, is just anatomy, because they know you don't really know the approaches because you're a third year medical student and you don't know anything, but you had anatomy and you should know anatomy. And so that's the other thing. Any type of procedure I was going for, I would review the relevant anatomy for the abdomens, just so start knowing everything. And then for more specific things, like for any of you shining ortho people out there, Ortho Bullets is your best friend. It's a website. It's free. Ortho Bullets is amazing. And they're also good for, like, even if you're going into family medicine and you have questions about any MSK, ortho kind of thing, you can go on there and it's like a quick bullet point, hence bullets, of relevant anatomy. And they have pictures, then they have like treatment, they have workup, they have the whole process for like osteoarthritis of the knee. Or if you get, a specific fracture, it's not just surgical stuff. They have the non-surgical stuff in there is what I'm getting at too. So if you have tennis elbow, you can read a whole little page on that. So you're more up to date on that stuff. And so then the relevant anatomy associated with things. Because again, that's what surgeons are going to pimp or ask you questions on is, they're going to just have their forceps and they'll be on something in the person, be like, what is this? And you feel like you're back in an anatomy lab in those tests and you're like, I have no idea what this is. Like, what the heck? It's even more complicated because there's blood everywhere. So,
yeah.
And you can't touch it to get a feeling of what is it? Is it squishy? Is it firm? At least not always. Yeah. So for surgery, that's what I would say. Just, look up what's going to be happening, what surgeries you're going to be doing, and then the anatomy associated with it. That would set you up very well for surgery rotations.
Yeah. And you actually kind of set me up perfectly there with that kind of pimping question when you don't know the answer. How do you respectfully say, I don't know? Or do you not even say, I don't know? Do you just kind of keep guessing?
So the guessing, I feel like that is well divided across students if you ask if it's okay to just guess. Definitely feel out the surgeon or any attending and see if it's okay. So if you're just guessing to guess, I would say don't do that. So if you're just throwing something out there, or at least if I do that, I make it known. I was like, this is a guess, but I would say blah. That may be a little bit more okay. In ortho specifically, I know they didn't like guesses, at least through my auditions. And so if I didn't know something, I would say, I don't know, but let me look that up for you and get back to you. Always make that offer of, I don't know it, but let me look it up and I will then tell you later. Sometimes that's just enough that they want to hear and then they'll tell you or they'll teach you. Sometimes they don't. I had one instance where it's straight up the attending did not teach anything and he just said, okay. And then left it at that. It was kind of weird. It just is what it is. Don't be afraid to not know something. Again, you're a medical student. You're a third year medical student. You don't know a lot. You think you know a lot because you just completed 2 years medical school and then you start clinical rotations and you feel like an idiot. So yeah, don't be afraid to not know things, but be willing to learn. And that's what that answer really embodies is, I don't know. I acknowledge here's a weakness of mine, but let me look it up. Let me put in the work to then learn it. And then what helps too is in that learning process, as you go home, you review it. And then if you have questions, that's almost even better to, just walking in and say, hey, Dr. So-and-so, you wanted me to look up SLAP lesions. So here's the criteria for SLAP lesions and the classification system. Instead of just approaching it out of nowhere, say, hey, Dr. So-and-so, I was reviewing SLAP lesions yesterday. I had a question about this one. So what's the difference between, a type 1 or a type 3 and a type 4? I'm not really understanding that here. That shows that you have processed stuff and now you're thinking a little bit and now they can enter in and they can teach you a little bit if they want to. So that's how I always approached that. I was never afraid to say I don't know. And I'll even say that to patients. If patients ask me something and I don't know, I'll say, you know what? Either that's a great question, because patients, you don't always want to say I don't know, but I have said it. I will not say I haven't. Be like, that's a great question. Let me check with the team. Let me check with the resident. That's something I would always do with patients. Or if it's some like off the wall thing, like, should I not drink milk right now? I'll be like, you know what? I don't know.
No, that's really helpful. And you are perfectly setting me up for all my questions.
Thanks for joining us for part 1 of Prepping for Clinical Rotations. Part 2 will be available on June 28th.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.